Good afternoon, everyone. This is Tim Lynch with the ABIM Foundation, and welcome to the Choosing Wisely Learning Network webinar. Please note that today's session is being recorded. Today we'll be hearing from Jason Reese with responses from Arjun Gupta and Lisa Latorno. I'll introduce each of them in turn, but first I'd like to share some information about a new ABIM Foundation program. If your practice or health system is interested in improving your patient engagement while reducing overuse tests and treatments, a new breakthrough series that's a collaboration between the Choosing Wisely Learning Network and the Patient-Centered Primary Care Collaborative can help you. In this 11-month collaborative learning experience, we'll guide participants through a PDSA cycle focused on reducing 2 to 3 too frequently used tests or treatments, with the assistance of expert coaches, group meetings, and targeted virtual conversation. If you're interested in learning more, please contact Kelly Rand at krand@abim.org. The information and Kelly's email address are also in the chat box. Turning now to our presenter, Jason Reese is the founder of the company Behavioralize and is on the faculty of the marketing department at the Wharton School at the University of Pennsylvania. His research examines how consumers make decisions and develop habits around products that affect their health, appearance, and performance. He is published in the American Journal of Preventive Medicine, the American Journal of Public Health, and Health Affairs, among other journals. He holds a PhD in psychology from the University of Michigan. During Jason's presentation, if you have any questions, please feel free to enter them in the chat box. Jason, I'll turn it over to you, and thank you for joining us.
My pleasure. Thank you. I assume you can hear me.
We can.
Yes.
Great. So, yeah, I've spent the better part of my career as a business school professor teaching marketing. So I hope that I can offer some patient perspective, but also some marketing perspective. The approaches in public health and medicine are not always 100% compatible with the approach taken in marketing, which is almost by definition consumer-centric. Through behavioral economics, the two approaches have come very much together in the past number of years, though. So most of my time the last few years has been spent on various kinds of consulting projects around healthcare and behavior change. So what I'm hoping to do today is offer you a framework. Many of the ideas and studies that I talk about, I'm sure, will be familiar. Some won't. I'm hoping that through this sort of barrage of ideas within a somewhat systematic framework, you'll be able to develop some useful applications for how to encourage wise choices in your own programs. I'm just advancing my slides here. So these are two names that in academic circles are now household names, really. Daniel Kahneman, who was my postdoc advisor years ago, as a psychologist, won the Nobel Prize in Economics in 2002, and Richard Thaler, an economist, won that prize last year. They're good friends and collaborators and have been very influential for a very long time. They have kind of established the foundational idea that humans do not make optimal decisions in all circumstances, and it's not just random noise. There are systematic ways in which our decisions and judgments do not bring us the best possible outcomes. Thaler's book Nudge with Cass Sunstein, released in 2008, was incredibly influential, and that phrase nudge is by now probably also a household word. And you may know that the University of Pennsylvania medical system has established a nudge unit. Mitesh Patel, a junior faculty member, is the director of that, and he works closely with David Ash and Kevin Volpe, longtime faculty members at Penn. Kevin Volpe is the director of the Center for Health Incentives and Behavioral Economics. Kevin and David established a consulting company called Val Health. I've worked with them on a couple of projects. around wise choices in the last few months or so. Point is, lots of activity here at Penn around moving physicians and moving patients towards wiser choices on a variety of dimensions, safer, more cost-effective, and leading to better outcomes. If you have not spent time on their webpage, I strongly encourage you to do so. In fact, this may actually be my biggest contribution today, directing you to this site. Just yesterday, they held a symposium, Nudge Unit in Healthcare, and some of the content of that symposium is described on the site. And I'll go through a couple of the studies they talked about today. Just a couple of comments from that session yesterday that I think add some nice perspective. David Ash said, you know, for generations, medicine has been about surgery and pharma, and of course it still is, but now almost as important are administration and information technology. Those are the functions that really allow and facilitate nudging at scale. The administrative head of the Penn Hospital system, Kevin Mahoney, offered an interesting perspective, which was that the Penn Hospital system and hospital systems generally used to compete on having the best and the newest toys and gadgets and technologies. Now they're trying to compete around integration. Who can integrate the different functions in the healthcare system the best to optimally serve patients? So those are some of the nuggets from yesterday's session. I don't know if this is going to show up animated, but I want to start with this point that thoughts happen quickly and automatically. If you ever get to see the animated version of this, you'll be blown away. It looks like the blue lines are moving when in fact they don't, they stay still, but it's just like any other visual illusion. You swear you're looking at one thing, but you're actually looking at something else. It was visual illusions like this that initially inspired Kahneman years ago to start thinking about and describing what he characterized as thought illusions, ways in which we think we're making smart choices, but we're not. So thoughts happen automatically, and I can tell you that cars are dangerous, and you understand immediately what that means. But feelings happen automatically as well, and they have a different kind of impact. You have different kinds of reactions and feelings when you see images like this, beyond mere thoughts. And actions can happen automatically as well. This is a great photo. This is a small town in Iceland. They have painted what looks like three-dimensional blocks on the road. It's just two-dimensional, but it's made it look three-dimensional. You sense immediately that you've got to slow down, and indeed people do. So both thoughts, feelings, and actions can happen automatically. And that has really been a unifying idea in behavioral science. We all know that the human mind evolved, but it's easy to lose sight of the fact that so many of our mental functions have origins in brain structures that are not hundreds of thousands of years old like humans, but many, many millions of years old like our mammalian ancestors. And this has led to another big unifying idea, which Kahneman popularized in his book, Thinking Fast and Slow, but by no means was he the first to articulate it, and he's been clear about that. The idea that there are really, that the mind can be thought of, at least metaphorically, as consisting of two broad systems. The fast and automatic system one, which is firing all the time and giving us all of these automatic thoughts, feelings, and action impulses. And then the slower, more deliberative system two, which is trying to keep track of what system one does, slow it down a little bit, and maybe make some adjustments, but it can never actually keep up, and it can never make all of the decisions that system one would ever make. So that really has been a unifying idea in behavioral science, and drives the way that most of us think about behavior change. A framework that I've been working with the last few years is to put behaviors into three broad buckets: knowing, feeling, and doing. And this is not revolutionary. It's simple language. It's been used in marketing for a long time. But one of the differences in the way the behavioral scientists think about this now is that it's not so much a sequence of knowing, and then once you know, you feel, and then once you feel, you do. These three can often operate separately, forwards, backwards, and even one without the other. So, of course, very often we know things without actually ending up doing them. So behavior change often has to go right to that doing bucket. And this has implications for many of the kinds of low-value care that you see being prevalent today. So I'm going to go through just a couple of quick examples of these behavioral problems in a general sense, and I think this should be familiar ground. We forget things incredibly quickly. This has been known since the 1800s. You can get information and forget it within minutes, and then, of course, not act on it at all. In terms of feeling, we tend to procrastinate. This is a great study from Suzanne Hsu and Ayala Ganese. They surveyed tourists and residents in different cities and found out how long it took them to get to different landmarks in the different cities. And tourists got to the same number of landmarks in a couple of weeks that the residents did in a few years because the tourists were on a clock. Otherwise, people procrastinated. The point here is it's not just for annoying things like medical appointments that people they procrastinate for things that they would otherwise enjoy doing. So we don't feel the right impulses all the time. Projection bias, a tendency to think that others like what we like, can do what we can do, and see what we see. And this matters because your administrators have a different perspective from your physicians, and your physicians have a different perspective from your patients. This is an example that I've used in my MBA classes for years. You ask people a couple of simple questions. One, do you know how to use a simple technology like Snapchat? And they answer yes or no. And then you say, what percentage of your colleagues or your classmates know how to use Snapchat? And sure enough, the people who use it themselves think that many, many more of their peers use it than do the people who themselves don't use it. We call that difference between the yeses and the nos in terms of estimating the frequency of a behavior in a population, projection bias. And this means that your administrators don't have the same concerns and priorities as your physicians and on down the chain. And there are things we can do about that. Status quo bias is familiar territory. We tend to prefer existing circumstances over change. The defaults that get created are incredibly powerful and important. Planning fallacy, we're not great at predicting plan completions, tend to ignore, we don't foresee the obstacles. This makes change difficult. And we don't just forget facts, but we forget to do things. We can make the best plans and then, for a variety of reasons, forget to actually do them. So we have these problems with knowing, feeling, and doing. Fortunately, we have behavioral tools that can help with knowing, feeling, and doing, and I'll go through a few of those. But the big takeaway here really is that very few behavioral problems are solved with a silver bullet. Behavioral designers should generally plan to develop what we sometimes call in marketing a 360-degree solution and plan on utilizing a whole variety of tools for a variety of problems. So this is a fundamental idea in Marketing 101. Understand your consumer's journey and understand the different touch points that you have to reach the consumer at different places in his or her journey. Here's a very bare bones template for the patient journey in a medical context: before diagnosis, then the time before treatment, and then during and after treatment. And there would be ways of reaching consumers and messages that you would want to give them at all those various points. And then your touch points would include direct mail at home, other ways of reaching them at home, ways of reaching them in the clinic. And if patients are also employees, various kinds of employment events can be opportunities for programs like Choosing Wisely. Especially times when people are new employees, that can be a great opportunity to start getting them to behave differently. So I'm going to go through a few examples, a few concepts from each of these know, feel, and do buckets. So a big one that you have probably heard something about in the context of behavioral economics is framing. There are lots of different ways to frame messages and problems that can change the way that people respond to them. You can frame the magnitude so that a problem seems smaller or more manageable. Here's an example in the context of trying to make people just more realistic about dealing with a little bit of pesticide residue. Is 10 parts per billion a lot or a little? Well, it's about 10 drops in an Olympic-sized swimming pool, which for most people makes it seem like very little. You don't just have to frame magnitudes, you can frame processes. Here's one of my favorite examples of this. Again, in the food context from the American Frozen Food Institute, freezing is nature's pause button. So the ideation process for you here would be to think about what are the kinds of processes that you would like to reframe for your patients or your physician collaborators? Would it be the adaptation process, adapting to pain, or something about the overall medical journey that they're going to go through that you can reframe in a succinct way that gives them a new perspective on it, that helps them know it just a little bit differently. You can frame prices, you can frame durations, so waiting times perhaps could be framed in this way. This is a famous example. Pennies a day seems like very little, $15 a month seems like really something. Simplicity is incredibly important with messaging. This is a fundamental idea in marketing, and it's of course increasingly appreciated in public health. This is a study that I did with my colleague Rebecca Ratner 5 or so years ago. We were looking at the My Pyramid food guidelines, the ones that had been replaced on it, were replaced a few years ago under the Obama administration towards My Plate. But we were looking at an even simpler guideline. At every meal, fill half your plate with fruits and vegetables. And that simple guideline, fill half your plate with fruits and vegetables, is incredibly easy to remember. Having to remember the exact amounts of food in different categories to consume during a day and try to keep track of that during the day is an extremely difficult cognitive task. It's no wonder that people weren't actually doing it. A simple guideline like this isn't enough, but at least it's something that people can picture and something that they can remember. And yeah, in the studies that we published, we showed that there were huge memory differences immediately after people were presented with these, with the simple guideline or the traditional My Pyramid guideline. So simplicity is kind of rule number one of helping them know it. And then brand it. You know, this is of course a huge topic in marketing and one that is maybe less appreciated in public health. Brands do a lot of things. They help people remember ideas. They help them remember them at moments. They create identity with different products. They create emotional reactions. But they're always simple, and the best brands have a nice way of capturing what the benefit of a particular product or program is. So here's a program that Jeep sponsored through the military, Operation Safe Return, makes clear what the benefit is, safe return for our military personnel. Of course, no one is better at branding than CocaCola. The simplicity, the memorability, and the clear benefit. I'm Canadian, so I'm not actually crazy about polar bears. They kill people, but there's an emotional resonance to it. And of course, this campaign is directed towards creating awareness of global warming, which is a reality. And the idea here is Arctic home. That's a simple idea. They've got a great visual for it, and it makes clear what the benefit is. These polar bears can't live without an Arctic home. So CocaCola are great branders. They are not a great public health force, but lots to learn from them about branding. So in the help them know it bucket, I suggest these three major implications. the value proposition. And again, this is marketing 101. Be crystal clear on the value proposition for whomever it is that you're trying to move. If it's patients, why should they choose wisely? Why is watchful waiting so wise? What is it doing for them? How can you make that simple and crystal clear in a phrase or two? Framing, what can you do to make that benefit as large as possible, or the harm reduction as large as possible, so that they have a new perspective on it? And then branding, and this one is often overlooked in public health circles. Choosing wisely, I think, is an excellent brand. What it doesn't have is a clear articulation of the benefit, what it is that patients get. I think it can work very well as a parent brand, but there's no reason why your own clinic, your own hospital can't create something like some kind of slogan or catchphrase or brand that makes clear to the patient what it is the benefit for them really is. And make that something that can be articulated and repeated all over the place so that people actually remember it. It's not just that they remember to then do it, it's that you create a memory for something that can then be recognized, so that becomes a platform for future kinds of future messaging campaigns that you will have later. So that's bucket one. On help them feel it, let me talk about a few different tools in the marketing and behavioral economics buckets. Me first, the personal benefit is more important in motivating people than doing good. Wharton is incredibly proud of Warby Parker, a company that was founded here by a couple of MBAs 10-some years ago. And they have this great campaign. If you buy a pair of glasses from them, they donate a pair to someone in an emerging market. And that's great, but the big driver for business for them is their incredibly low price, $95 for a pair of glasses, which is much, much lower than people were typically paying. It's also a very easy process. You go online, they send them to you, you pick one, you send the other ones back. One less thing to think about. It's convenience and it is savings that motivate people. They're, of course, happy that they're doing something for the rest of the world, but that is not the main driver. It's the money saving and the convenience that has made this company a billion-dollar company. Helping people see things concretely and see downstream benefits concretely is an idea that many people have been chasing, many academics have been chasing for years. Hearst Felton and his group have had a few nice studies that found a clever way to do this. They've done this in the financial services domain. They show undergraduate students either a digital image of themselves or a digital rendering of themselves that has been morphed such that it looks like they see themselves roughly as they would look at age 65. And these pictures are incredibly compelling. You can actually see, if you're a young person, you actually see that is you in that picture when you're older. And simply exposing them to that picture of themselves in the future made it concrete to them that they were actually going to age, and it made them more inclined contribute to their retirement fund. And they've replicated that in a variety of different ways, in several cases with real money. So there's no better way to make things concrete by showing you that this will happen to you, but showing you that this will happen to other people who are like you is often a decent substitute. I mentioned projection bias earlier, where we are not so great at understanding the priorities that other people have. So the variety of perspective-taking interventions that are out there. This is a great one designed by Ford Motor Company engineers. So here is a Ford engineer wearing a third age suit. So this is a get-up that helps her experience life as a 70-year-old or 80-year-old driver. A bulkier frame, thick gloves that inhibit mobility, and the glasses that reduce her visual acuity. That gives her the perspective of an older driver and changes the way that she might think about setting up the display. You won't be able to do something quite as elaborate as that probably in your context, but what can you do to give the administrator the physician's perspective and the physician the patient's perspective, to make them feel what that person's priorities will be. Another way of getting people to feel things is to take advantage of moments when they tend to naturally feel inclined to do things that are good for them. This is an example from a series of studies that I was involved with, studies that were led by Heng-Chen Dai, who's now at UCLA, and Katie Milkman, who's a senior faculty member now here at Wharton at Penn. So we were interested in the times, identifying times when people exercise most, when they were most likely to eat healthfully. And we found, of course, it's, first day of the year, the New Year's effect, go to the gym more, people start diets then, it lasts a couple of weeks. But it wasn't just then. First day of the week, first day of the month, first day of the semester, in the school context. By the way, these are days, increased likelihood of going to the Penn gym among a sample of a few thousand students. First day after a school break, first month following their birthday, these were all significant predictors of increased inclination to do something that's good for you. So we think those are key moments for behavior change and ones where there's a real opportunity to build. Another idea that's sort of in line with this is taking advantage of people's inclination to keep up streaks. So there have been a handful of studies that have showed that streaks are very motivating for people. If they've done things 3 days in a row, they'll want to do it that fourth and fifth day. All of the digital apps that we're addicted to take advantage of this. They often go so far as to tell us that we have a particular streak going and that we should keep it up. The picture that I'm showing you here is from George Wu, a faculty member at the University of Chicago. He did some analyses. This is when running streaks start, and a very large disproportionate percentage of them start on the first of the month. So that's combining streaks with fresh starts. There may be opportunities for you to start choosing wisely behaviors on the first of the month and encouraging people to keep streaks of choosing wisely going. So the implications in this bucket, perspective taking, help the physician understand why the patient may need a nudge, making things concrete, making the benefit concrete so the person feels compelled to go ahead and do this behavior, taking advantage of fresh starts, and taking advantage of streaks. These are kind of natural opportunities to take advantage of people's feelings. The last bucket that I want to talk about is perhaps the most important one. This is going right to the doing behavior. This is a slightly crude image, but you may already have seen Richard Thaler show this in one of his many large public addresses. He's got this great quote: if you want to get people to do something, make it easy. Here's the famous fly painted onto the urinal. Some ways of making things easier: script the critical moves. So if you're trying to get a group of physicians to implement a program or share a particular message with their next 100 patients, you've got to script that for them. You may even need to go so far as to get the script somehow embedded and created as a prompt in a medical record, or hand them an actual physical card. But that scripting is something that an administrator can do to get the actual script right, rather than forcing people to ad-lib it or even remember it. Normalizing behavior, making it seem normal to prescribe the generic or to wait before prescribing an antibiotic, or making it seem normal before going ahead or pursuing an aggressive strategy. Can be very effective. It's been shown in a bunch of different contexts. I'm showing you some of the famous studies here. I'll just briefly mention them. One of the first famous demonstrations of this was with guests at a hotel chain. Simple intervention: you put a sign on a door that either says, use your towels again, it's good for the environment, or you have one that says, 75% of the guests in this room have done good for the environment by reusing their towels. Dramatically increases towel reusage when people know that others have done this. The company O-Power has helped utility companies share information for individual customers about what their neighbors are doing, and people use that social comparison to make a judgment about what is normal and what they ought to be doing, and that's been shown to reduce power consumption over time. And then a paper that was published, I think, just the last few weeks, changing behavior around statin prescribing through a variety of mechanisms, but including peer comparison, letting other physicians see what others are doing, increase the effectiveness of another intervention. So normalizing behaviors, many ways of doing it, often through simple communication, can be very effective. Providing just-in-time information. So this is a study that I did a number of years ago. We were trying to get people to eat a little bit less. We knew that many people knew that they ate too much whenever they ate out at quick-serve restaurants. So we got this chain to cooperate with us, and the clerks said, after you've ordered, would you like to take a slightly smaller portion of what it is that you just ordered? And in some contexts, about a third of people said, yeah, actually, I would like to take a slightly smaller portion. People often know the right thing, but if you can remind them at just the right time, they're more likely to do it. Here's another example of how simple reminders can go a long way. And there's maybe no intervention that's easier than this one. It's done through a workplace wellness program. So these two images that you're seeing are two different mailings that were sent. People were randomly assigned either the one on the right or the one on the left. The one on the left just shows the times when a flu shot is available at the on-site clinic. So 5 different days, available all these times, drop by whenever you feel like it. The other one, just a tiny change, it invites you to add in the day, the time when you're likely to go. So it just has this extra little bit of text. There's nothing binding about it. You didn't have to mail this back in. You didn't even have to write anything. There's just this extra little script. Many people find it helpful to make a plan for getting their shot. You can write yours here. Just having that there, the thought is, made people more likely to make a concrete plan for something that they kind of knew that they needed to do anyway, and just making that tentative plan made it more likely that they would actually go. A couple more examples here for you. This is perhaps the most important tool in the behavioral economics toolkit, making the default something that is an appropriate choice. The famous example that's been around for a long time is opt-in versus opt-out policies with organ donations, and you've probably seen versions of that study. Here I'm showing you the organ donation rates in Austria and Germany, 2 countries with fairly similar cultures, but with very different policies around organ donation. In Austria, you have to opt out. 99% of people end up staying in. Germany, you have to opt in. Only 12% of people do it. There's no way that is there is some deep underlying preference around that. It is just the nature of the default that's changing that very important behavior. Here's another study that was done by the Penn Med unit led by Mitesh Patel. They just changed one box in the medical records. I think this was done after they had implemented EPIC. And it was just one default box that changed whether or not a generic was prescribed or whether the brand name medication was prescribed. And there was a huge increase, almost up to ceiling, for most medications towards the generic. And Mitesh has made the point that what's nice about this is it suggests that that physicians were not, it was not just the case that physicians ended up prescribing generics thoughtlessly even though they may have had a different preference, because there is one particular indication where the generic was not as consistently prescribed, and it was thought that that was a case where there actually was a difference between the generic and the branded medication. So this does not completely eliminate attention that people pay to the choice at hand, but was incredibly effective at increasing prescription behavior of generics in a large health system. If you can't change the default, you may be able to create an active choice opportunity. This is another study from Patel's group where they use something called active choice. So rather than setting the default, you sort of force people to choose. And in this case, it was either to cancel or go ahead with the flu vaccination. And just forcing that choice created an increase in the percentage of people who were, percentage of physicians who were getting these flu shots to happen. So the implications in this do it bucket, make it the default. It's not easy to do, and you may not even be able to create the default being the actual behavior you want, but you may be able to create a default for an appointment to learn about the benefits. This is something that we've tried in a workplace wellness program. All new patients who are being inboarded are kind of almost defaulted into an appointment with a coach who's going to talk to them about the system and give them all kinds of advice. Normalize it. Phrases like join thousands of, this should say patients like you who are waiting before using antibiotics, or I guess in this case parents works as well. Prompt when possible. Write down the location of your nearest lab so you actually get there. Reminders just in time. Can you put a little reminder for a certain kind of behavior on an insurance card? And then script it when you can to get people actually using the right words at the right time and to make it easy for them. All right, that was a lot of ideas. I hope it gave you a few useful thoughts. The overview, make sure that the benefit is clear, make it crystal clear, and make it easy to remember and for people to be reminded of. Make it easy to do the thing to get the benefit. That's maybe the most important lesson here. And then there's no silver bullet. Expect to use a comprehensive approach to any kind of behavior change that you want to implement. Thank you.
Well, Jason, thank you so much for that excellent presentation. We're going to hear from two respondents now who will offer some thoughts and probably ask you a few questions about your research and your presentation. Our first will be Dr. Arjun Gupta. Dr. Gupta attended medical school at the All India Institute of Medical Sciences in New Delhi. He completed a residency in internal medicine at the University of Texas Southwestern in Dallas and is the chief resident for quality patient safety and high-value care at UT Southwestern. And recently, he was the inaugural Teaching Value in Healthcare Learning Network Fellow for Costs of Care and the resident director for scholarly activity for the High Value Practice Academic Alliance. So please, Arjun, take it away.
Well, thank you so much, and thank you, Dr. Reese. I just wanted to place what you spoke about in the context of a behavioral change model and addressing behavior from multiple dimensions, like you said, sort of in a 360-degree model. And one such model is the behavioral change wheel, also called the COMB system, or the capability, opportunity, motivation, interacting to generate behavior. So C is capability, O is opportunity, M is motivation, and all of them influence behavior. So capability is having the necessary knowledge and skills to engage in an activity. Opportunity includes all of the factors outside of us that allow us or prompt this behavior. And motivation is our internal brain process that's sort of directing this behavior. Some of the things that we've noticed in our high-value care or quality improvement studies in medicine is that most projects only reduce the measure we're trying to reduce by a very modest 10 to 30%. That's not insignificant, but it's often not enough. And one thing that we've noticed in common with a lot of these interventions is that they're educational interventions alone. which in my opinion only address the capability and the motivation, but don't really have the systems changes, the hard stops, the EMR defaults, the restrictions, which really affect the opportunity of the individual to change. So to give you an example, if you remove a test from the electronic medical record and force physicians to use paper entry forms, testing has been shown to reduce by 99%, sort of playing on the sorts of things that you highlighted about having defaults and physicians having status quo bias. And this sort of change addresses the opportunity. To give an example of a project, we tried to reduce rates of in-hospital use of fecal occult blood tests, which is a simple laboratory test. And despite what we thought are our best educational efforts, testing reduced by a very modest 15%. Similarly for the neutropenic diet as well. And what's remarkable is that when you remove the test completely from the electronic medical record, testing went down by 99%. And even providers who initially insisted on ordering the test and that they absolutely needed it were not going through the 2-minute process needed to order it through a paper method. So I understand that not every intervention is suitable for de-adoption, but I think this framework gives us an idea about how physicians' minds work. And medicine is obviously complex, but it probably indicates two things, that A, our current high-value care projects are probably not branding themselves well enough, and we may need more subtle or even not so subtle nudges for these interventions to work.
Yeah, I think that's very well said, and there are, I think many frameworks that can get us roughly to the same place, which is a recognition that, even if we have people who are conceptually aligned wanting to improve the quality of care, so many things happen in the key moments of decision, and there are so many distractions that getting ownership over that moment is just incredibly important. And this is actually one of the reasons why I think it takes such a collaborative group in a clinical setting to make these things work. You need the administrators, you need IT to the extent that things are happening through the medical records, and most importantly, of course, you still need the clinicians who are making the decisions about what the priorities ought to be and understand the workflow maybe better than anybody else.
Perfect, thank you.
Thank you, Arjun. Our next respondent is Dr. Lisa Latorno. She is a physician leader with a particular interest in advancing primary care and patient engagement efforts. She previously served as Executive Director of Maine Quality Counts, a regional health improvement collaborative, where she led several quality improvement efforts, including the Maine Aligning Forces for Quality Initiative and the Maine Patient-Centered Medical Home Pilot, as well as Choosing Wisely work. She's a graduate of Brown University and the Dartmouth Brown Program in Medicine, and is a board-certified internist who practiced emergency medicine for 7 years before beginning her work in clinical quality improvement. She holds a master's from the Harvard School of Public Health. Lisa?
Great, thanks. I got to shorten that thing. Thank you so much, Jason, and thanks, Arjun, for your thoughtful comments as well, and everyone on the call. So I tend to be a very concrete thinker, Jason, and I go right to one of your 3 big implications about halfway through the presentation, which I love. Be crystal clear on the value proposition, frame the benefits to be as large as possible, and brand Choosing Wisely in a way that more clearly states the value to patients. So I was thinking about some of that as you were talking, and I thought, how about something like Choosing Wisely? It will save you money and could save your life. And I immediately thought, that's probably too much. So I'm wondering, my question is to, take you up on your very, I think, helpful recommendations. How important is it for clinicians? I'm thinking of, whether it's clinician groups, maybe primary care groups or, health systems, to really marry the very helpful approach of Choosing Wisely with your very practical approach of behavioral economics. how much testing would they have to do? You know, is it if we don't all have a nudge unit, which sounds like an incredible resource, and I'd also love to hear more from you about that. How common is that? How can folks who are, you know, on the call or otherwise clinicians in the field, you know, link into expertise like that? But how difficult is it to implement these kinds of recommendations? Would one really want to go through formal focus group testing? You know, you just try something. How would you really make some of these things real in practice without? And what, you know, how do we know what alienates patients? You know, with saying things like, you know, obviously I just made this up on the fly. Save your money and save your life. What goes too far in terms of alienating patients or versus attracting them, and how do we know? How do we know what to do with it?
Yeah, it's an important question, and I appreciate that you may be operating in some circumstances without you know, a whole marketing department behind you. I think the safe thing is to start small, and if it's a particular problem that you're going after, you start by asking patients, like, what is the benefit that you would see from this? Start with their own words. And if you find a few examples that seem to resonate, maybe you can develop some messaging around that. Yeah, of course we'd want to test it. You know, both with simple online tests where you see if people understand it and if it bothers them, and then in field tests. But if you're starting small and if you're doing it locally, you know, you don't have to. You could just be sort of sensible and cautious as you develop things and try. So that's point one. All that said, there are some very cheap and easy ways to test things, not necessarily with your own population, but there are online panels now that allow you to run responses by people for $1 or $2 per person. So you don't need a huge budget, not necessarily, to get some initial feedback. Nudge units are not cheap. At Penn, it started with one faculty director and, as I understand, 1.5 full-time employees. But there was buy-in throughout the organization in this large hospital system through IT, through administration, and through many of the clinical groups. Now, they started small. They started with some studies where it looked like it was going to be easy to actually try it. Studies where they were looking at defaults, which we know is one of the most powerful ways of influencing behavior. And they got a few early wins, some papers that got published, and now they have a lot more latitude to try more things. They've got money coming in from grants in different groups. There are now, I think, something like 20 people at Penn involved there, but many of them are paid not centrally, but by grants to particular researchers within the system. So it starts small and it grows. They are trying to develop a collaborative where people in health systems anywhere can learn about the approach that's being taken and share best practices. So the website will provide some details around that, but I think you should expect more of that to come. I think the sooner you get to know that group, the better.
Great. Can you mentioned online testing sites that you could test a message for $1 a line or issue. Can you just say a little more about that? I'm not familiar with that concept.
Yeah, so I mean, the one that a lot of academics are using is Amazon's Mechanical Turk. People can use Amazon. People can go onto this platform and get money that they can use on Amazon by completing surveys. So you could just set up an account as someone who runs surveys on that site, and you can get people to sign up and do your surveys for 25 cents to $1 or more. The more you pay them, the more high quality respondents you can get, because Amazon does allow you some ways of screening them. But that's the cheapest one. But then there are others. I mean, Google has some, I can't remember the name of it, but Google has something similar where you can post one question and get a bunch of responses the same day. Company Qualtrics has you can get a free survey account there, and then you can design the survey simply. It works almost as easily as Word, and then they can connect you with people to do your survey. It's a little more expensive, more like $5 a person, but the panel is a little more professionally managed. Those are some examples of that kind of low-cost approach.
That's great. Thank you. That's a new one to me.
Of course.
Great. Shall we open it up, Kelly, to other questions?
Sure, and I'm unmuting all the participants, so you are welcome to chat your question, and you're also welcome to ask your question aloud. While we're waiting, Jason, I know we talked a little bit about watchful waiting, and it seems like from a clinical standpoint, a great option for things. What are some ways you might suggest for clinicians to make that a more attractive option for patients?
I mean, I think finding explicit but appropriate ways to make clear the risks of not watchful waiting, of rushing into surgery or some other approach, making that vivid, describing a case where you saw someone who didn't wait and they suffered for it, reminding people that we have there are many kinds of imperfections that we have to live with, and we can get used to things. So framing the process and saying, the fact that you have this slow-growing tumor is something that now it's very salient and you can't take your mind off it, but it will eventually be, fall into the background of your life and become just another thing. Language and processes like that, or applications of some of the concepts along those lines, I think can be very powerful.
That is helpful. Do we have any, here first, Jason, do you have suggestions about the most appropriate means of engaging with patient consumers in light of changing communication trends, like social media, email, phone, direct mail?
I think, honestly, the biggest one that I have is text messaging. If you can find ways to be texting your consumer, your patients, reminders or just-in-time information, that's going to be the most powerful. People read their text, and if you can sort of establish a trust level where they don't mind getting those messages from you and where you don't mind sending them, I think that's the most powerful one. Even more so than any of the social media.
Great. Any other questions for Jason or Dr. Reese from either the audience and you, or you are allowed to speak aloud?
This is Lisa. I'll jump in again. Either Jason or anyone on the call, can you think of an example where you've seen a choosing wisely recommendation that has best been translated using the concepts of behavioral economics? And again, anyone on the call, whether you're doing it yourself or seen it otherwise.
I mean, I'm going to just refer you back to the Penn Nudge Unit. Yesterday, they were describing a whole series of programs around moving people towards generics. They were getting some of the major the usage of major diagnostic tests reduced in cases that were not, where it was not appropriate. the papers are there on their site. They're being published in places like JAMA or JAMA Open Network, so they're not hard to get a hold of. Not being a physician, I don't know enough of the details for you about the exact programs, but they publish quickly, so the stuff is there. There are examples. It is being done.
Right. Yeah, I'm looking at right now variations in flu vaccine by clinic appointment time and active choice intervention in the EHR. Maybe could be one of those.
Yep.
Well, this is Tim. I'd like to thank Jason and our responders and all of you for joining us today for what was a great presentation and discussion. So I hope all of you have a wonderful evening, and we will be in touch soon with the topic and information for next month's Learning Network webinar. So thanks to all.
Thank you.
Thanks so much.